I have like actual tea. All right, and I could have tea too, but I'm that. How are you? It's been a long time, sir.
Man, it's been a while. You in the last episode, you were on with Bianca. You and Dr. Bush talked about anxiety. Great episode.
Anxiety, right, which was fun. I always love catching up with Bianca. She's so much fun. She's doing such great work. So
yeah.
So I've learned a lot, and it's been a good time. So how have you been?
I just came off of a 7-day stretch in the ICU, 7 on. I'm off for the next 7 days. Time to catch up on podcasting and life stuff and paperwork, writing a paper, doing a presentation.
Okay. You're more productive than I am.
Well, that's the plan for the week. We'll see what I actually
the week?
Get around to.
Oh, man. That's my plan for the week is survival. That's the goal for today. Go for the week, man. It's the holiday season, so our birthdays are coming up. People don't know, but we're actually very close in age.
Yeah, a couple days off.
Right. And so December is always a very busy time.
Wait, where's that? I thought you were older than me.
I'm not older than you. Don't do me. Wait, actually, I am older than you. Wait, am I older than you by what? We're born the same year, though, aren't we? 87?
Yeah.
Yeah. So you're what? No, you were older than me.
Yeah.
Because you're older. You're the 12th.
The 12th. Yeah. Okay. A couple days.
Wow. Yeah. I was born on the 18th. So you also should tell people those really good news about something that happened recently.
I did. I think, I announced it on a previous episode, but yeah, I'm board certified in anesthesia and critical care. Clearly, you don't listen to the show unless you're a featured host.
It's my level of narcissism. I only care about things I'm involved in. I'm kidding. Congratulations. How's it feel to be like officially done testing after doing so many years of exams?
I got to the Pearson VUE testing center and I realized just how like traumatic that place is and how much time and money I've spent going to these testing centers over the years. Horrible feeling.
Right. So it's PTSD. I remember taking step 1 in Philadelphia, and still every time I walk past that testing center, I'm just like, oh, my heart. It's like indelible in my mind. It's that I know people have read that book, The Body Keeps the Score by. Every time I mention some type of literature,
it's a big
I never
name,
remember the freaking author. And
The Body Keeps the Score. No, somebody was like, "Oh, you should read this." I tried reading. There's another big name book that people always read, except it was very boring.
Oh,
something about the heart or breath or something.
Oh, I don't know about that one.
Body Keeps the Score.
Right. It's Body Keeps the Score by Bessel van der Kolk, who I believe is a physician, if I remember correctly. And
can you summarize it, Chat GPT for us?
So it's a book about trauma and how it's a book about trauma that ties both your body and mind and brain, and how even though you may physically or mentally think that you're past something, that there are certain aspects of your body and your other parts of your spirit that sort of remember trauma, and it's always indelible on your body. So you think about walking past the testing center, like you don't really think about step 1 or your prior boards every single day, but seeing that may trigger something and your body is remembering it. So your body keeps the score as a sort of like semblance of what it's like for trauma, and how both your mind, body, and brain are all tied together and how you respond to trauma. And I think Dr. Van der Kolk is a physician. I don't remember what specialty. I want to say neurology, because it's actually really good for medical professionals because it is written fairly technical, but not in a way that's unreadable, because clearly it's a bestseller. But yeah, that's Nate Jones's book of the day. Of the month,
quarter,
yeah.
Depending on how much you come on
like a Oprah's book club or something. That'd be good. My therapist actually recommended that to me, I think, when I was 5 or 6 years ago. It's a really good book. It really does help understand where trauma comes from and how to untangle some of the trauma responses that we have, lower what Bianca and I talked about, Dr. Bush and I talked about, was lowering that sort of like anxiety and uncoupling the stimulus and the response. So it's a good book.
There we go.
Yeah,
I gave a book recommendation on last week's episode, which was Never Split the Difference, a book on negotiating.
Yep. Actually, you bought me that book. It was a gift.
Did you read it?
Clearly not, because my negotiations were not. I'm kidding. That's a joke. But no, I did not. It's hard. I have just a long list of books to read, but I use those types of books for when obviously I need them. So I've not been in negotiations in a long time, but if that time ever arises, I will definitely pull that book back out. So we'll see.
Yeah, I gotta get like a referral link or something with Amazon so I can get some money off of this.
Wait, a referral from the podcast or from just personal stuff?
All these these book recommendations. Click the link and then get some money.
There you go. It's just profiting.
You wouldn't have known, but on the last episode, I did announce as part of kind of the SNMA programming coming on their 60th year anniversary, we are doing a give back program. If you leave a review on Apple or iTunes, whatever, Apple Podcasts, we're doing $5 for each. Yeah. Well, yeah, you do Spotify too. I gotta look at how many we're starting with on Spotify. Okay. We're starting with 90 reviews on Apple. Okay. Actually, let me look it up.
I think you have 90 something on Spotify, or 60 something.
Oh, really?
I think so. Last time I checked. Obviously, we have to edit this out.
The Black Doctors podcast on Spotify. Let's see. 24 reviews.
Okay, that's your
on Spotify. Okay. So there we go. So for each review on Spotify or Apple Podcasts, we're doing $5 each. We're going to donate it to the SNMA up to $600.
Nice.
And that's going through the end of the year, so we can contribute to their programming.
Nice. How's that been going?
I honestly haven't.
Just announced last week.
Well, I'm not really keeping track of the numbers just yet. By the end of December, I'm going to sit down
and figure out how much calculate.
It was. Yeah. Right, so go ahead and share away, make a post or something. I don't know.
Yeah, you can put that as the outro of the episode, of each episode leading up until January. Yeah. So that'd be pretty cool. So we're just talking shop, talking admin stuff.
I feel like as we're trying to figure out what to talk about this episode, I sent you that tweet, but the culture of medicine, I think, is one way to summarize it, because there's so many things that we do or that we experience. You talked about the body keeps the score, all of the traumas of graduate medical education, of medical school, and there's different kind of nuances. And we've talked about it before, that transition from being a medical student on to an attending and how we perceive things differently. And I remember like when we were recording that episode, I'm like, there's so many things that we can't mention. You don't really think about it until it comes up.
Right.
And so here we are.
The culture of it all. Yeah. I think there are so many things looking back at understanding the culture of medicine. And I think particularly as Black physicians or any Black or brown or any like marginalized groups in medicine, there is a distinct understanding of what it's like to enter a space that's not necessarily built for you to prosper and even to exist in some level. And I think that is a heavy weight that a lot of people have to carry. And I think that culture speaks to that. I also think that it also just hurts. Like, speaking of the body keeps the score, I think being in those spaces, I think it just hurt. I don't know how many people walked into the OR for the first time or followed like a very scary attending in a clinic or something and have comments be made either about you or towards patients. And just the fact that you're sitting in this culture that does not allow you to be the best part of yourself or celebrate all parts of yourself hurts sometimes. So for me, that's what I've learned in terms of understanding these sort of cultures, and also the power that we have as learners, but also as teachers, to create cultures within the sphere of influence that we have. So for me, that is like during either a session in the medical school, or if it is a shift in the ED, creating that culture of safety, creating that culture of like inclusivity and just belongingness. Not only does that spawn learners to want to learn and to ask questions, but also models the behavior to perpetuate that culture when they become teachers. So it's like a dual sort of cycle. So that's my spiel. And
sometimes I'm a optimist, but you always keep me grounded. Do you think the culture of medicine, compared to the back in the day, it's gotten better, right?
I think so. It's hard because I think we've switched over to so many different institutions. So I'm trying to see was my time terrible because I was at that one institution, or was it just because it was a different time? But I want to say overall, I think that the trajectory there's been a lot more focus on it, at least I will say. Yeah.
I think it's funny how like the buzzwords exist in medicine, and especially for people that want to publish or you're on the promotion track. Some of the recent buzzwords are DEI and wellness, which they start off as very important concepts that need to be nurtured, but then it's like people jump on and I can just publish anything on DEI. I can be the wellness coordinator and I can do all these things and it's great on the CV, but are you really affecting change?
Right. I think there's a real, I'm going to stop saying there's some really good stuff out there and not remembering the names of these titles. But
well, remember later I'll put them in the show notes.
Right. There's a really great article in Forbes that talks about DEI work. This is particularly in the corporate realm, but that was talking about who gets to do DEI work and who shouldn't. And really what you're saying is there's a combination of not everyone who's experienced discrimination should do DEI work, and not everyone that studies the corporate model or the model of how to do DEI work should do DEI work. It's both an intersection of both lived experience and learned methodology in some ways. So what I'm trying to say is that, yes, being a Black person, could you do DEI work? Sure. But there's a lot of like evidence-based ways of doing it. And it's almost like knowing how to do it and also contributing to a lived experience both matters. So I will try to find that article in some way.
Yeah. And I appreciate talking to you because you do a lot in these spaces, but then even the terminology of I've published on healthcare disparities and trauma and some of the ethical components of this, because my field is my niche is medical ethics.
Right.
But having this on my CV and being my complexion, all of this healthcare disparities, ethics, it all gets rolled into, oh, you do DEI. And it's just so funny, the assumptions that are made. And, oh, yeah, of course you're the DEI person.
Right. Well, it's funny because like I've done equity work before it was called equity work. Like equity is a relatively new term that we've used and learned and try to understand. And I think it's used, so it's thrown around, just like you said, it's thrown around all the time. And there's a really good clip with Bernie Sanders talking to Bill Maher and trying to use the word equity. And you think Bernie Sanders would know. And I'll add that to my list of things to add to the show notes as well. It's a good thing It's a good thing to laugh at. But it's interesting. I think people just put it as a wastebasket term, right? Well, we have to do medicine and then we also have to do equity work. And it's, well, that's intertwined. They're not separate. They're not check boxes. They're not wastebaskets. But I think as people of color, as physicians of color, I think people assume that you want to do DEI work purely because your background is marginalized or minoritized. But I think for me, my journey in equity work, I started when I was in college. My background was I did anthropology, and I was really interested in political power systems. And I was
your undergrad degree was
in anthropology? Cultural anthropology, yeah. And I was really interested in political power systems, and I was studying the political systems of Kenya. And of course, I was supposed to go there for study abroad. Unfortunately, there was a whole political unrest in Kenya in I think 2008-ish, and my whole trip got canceled. So then I had to go study the stuff of
darn, poor you, Nate.
I know, not the whole country. Again, my narcissism shows itself every now and then. But so then I had to do this whole thing in New Brunswick, New Jersey, and try to understand their political system. But long story short, I learned very quickly how political power is obtained and institutionalized. And I think that led me down this whole road of I went from an ethical standpoint, from like a bioethics standpoint, as part of the Bioethics Society at Rutgers University. Go us. Yeah.
I didn't know you were into ethics.
I did. I co-founded this society. We published our first journal, and they're still out around today. I actually looked up online. I was like, wow, they're still doing this. It's so cool. And then went through the AMA and the AAP and all these medical organizations. And then equity work started becoming a bigger deal, especially in 2015, 2016. And then now my whole journey, and through that process, I was doing policy work. So I was doing a lot more advocacy. And to get to your point about, well, what is the final outcome? What is the things that we actually are? What is tangible? And to me, when I got to my current job, I was hired with a background in obviously equity work. And we do have an equity component of our division. But I realized when I got there that the work that was going on didn't really speak to me. And also, I really wanted to figure out a different way of applying equity that wasn't so advocacy focused. And so I was learning more about ED operations and quality improvement work. And currently my work right now is looking at how do you operationalize equity in a QI framework, which I think is a lot of new work, especially in the last 10 years, is really trying to understand that. So lots of long journey to say is that for those who are interested in equity work, it doesn't necessarily need to be all in advocacy, and that you also don't need to do it if you don't want to do it. And so I've learned how to say no to certain opportunities because I think they're not on the road in which I want to go on. And there's definitely people who would want to do it, and it's just, I'm an MIT. So,
and I think what you said in that is there's the push that I am the DEI person as opposed to one, you have all this extensive training and knowledge of this structure, this concept, but now you're doing it through the lens of quality improvement. And for myself, I do it mostly through medical ethics. And I'm like, okay, in the ethical space, there needs to be a focus, a perspective from somebody from a diverse background. And I think it's so important, as opposed to being a DEI person first. Right. You could be quality, you could be leadership, you could do all these other things. Right. And within that, you're speaking out for the disadvantaged and increasing equity. And
I don't know what your thoughts are about this, but I also feel like sometimes doing DEI work, depending on the institution that asks you to do it, can be career limiting in some ways. I feel like the people that I see ascend, at least in the medical institution, largely obviously are largely white men, but but also like I find those, particularly those in the advocacy realm, and those in the sort of and even smaller niche, the equity world, they don't usually ascend as quickly. And if they do ascend, they're ascending in a role that's specific to equity. And so I don't know, for me, that also rang into my decisions of like how I decided to go about and in a way of, well, I can further my career and increase longevity of my career and also apply these principles of equity in the work that you do. So I don't know if it's a similar process that you thought about.
I agree, because I sit back and observe a lot and I try to look at things from other people's perspectives. One of the things that I've noticed, and again, this could be anecdotal, I don't know if there's any truth to it, but as these departments and all that are like, oh, hey, we need equity, we need this, we're going to create this role.
Right.
And then they take very experienced, outstanding candidates and they'll recruit them in and be like, you're the XYZ of DEI.
Right.
And my thoughts are maybe they should have been vice chair of a department or a vice president of the organization. Maybe they should have had this role. And under that, they can do DEI as opposed to we built you this spot. Right. Because what we're seeing now, especially with the Supreme Court ruling, is that many institutions, all that support for these roles has gone away as legislation changed or the political climate changes.
Right. I do agree. I think the political environment has been less than favorable for equity work, particularly now. But it ebbs and flows. There was a small passion project of mine is look back historically of like how equality and equity work has ebbed and flowed and like the actual start points and impetus. I don't know.
That's right.
That started because if you think about it, 2016 was a huge role for like with equity. That's during Trump election and going into that. And Trump fueled a lot of focus on equity because he was so divided. Then there's even a higher jump in 2020 with George Floyd. And some may even argue even before 2016 with Trayvon Martin and those things as well. But equity work has not been something that just started in 2014. So, and it is continually starting to grow. So it's always that phrase that history always bends towards progressive. I think overall equity will always be a thing, obviously, quote unquote, a thing. But I'm just curious because it seems very cyclical. History always repeats itself, right? So you always have these processes of we're very progressive, and all of a sudden there's a progressive backlash, and then we become super conservative, and then we go back to being progressive, and then we just go yo-yoing back and forth. But it seems to be that the net gains tend to be more progressive. And so one of the bigger questions I have is historically, and if anyone knows about this, it'd be great. Like, how has the ebb and flowed? And in a way, does that actually predict the future? How it can better inform our efforts now? But that's a passion project that's never going to get done until I retire in the next 50 years. So we'll see.
You can wake book about it. I'm so fascinated. Right? The physicians that write books.
Right. No, I don't. I barely can write these papers. Books seems like a lot of work. I don't know. I feel like discipline needs to happen in my life. We'll see what happens.
We, and talking about that culture medicine, part of this was inspired by this tweet, a Twitter tweet. I was interviewing somebody recently and they're like, do we still call them tweets because it's on the app?
What are they called? X's? Do we call them X's? What do we call that?
And there's so many good conversations that are started on X, but you obviously cannot like fully have these civilized discourses on the app. But I sent you this tweet. The tweet is by a resident. And the tweet reads as, it baffles me when attendings are rude and condescending to residents. If you don't want to teach others or lack the skill to teach, why are you at a teaching hospital? And I've understood that from different perspectives, being a medical student, resident, and now attending. So I thought that was something we could unpack and share maybe some perspective. And I don't know, we may disagree, but I don't know. What are your thoughts?
My thoughts are always, I am such a strong proponent of safe environments. It's been shown time and time again how when you create safe learning environments, it benefits the learner, it benefits the teacher. And like I said, it perpetuates a culture of safety. And I think when we, especially in medicine, when we forgo the needs of our trainees and students, it does beg the question, well, what are you here for? If you're here to take care of a patient, that's good. You don't need to teach to do that. You can do that without trainings or students. If you're here to be in the academic setting and in the traditional sense, do both teaching and research and all the good stuff, well, then you do have to have a skill set that's required of that. And I think in the past, in medicine, as long as you've had like an MD or PhD or done significant research, it was assumed that you would also be able to teach. And to be able to teach would mean to just the most rudimentary way of just being able to give information. But it was not seen in the holistic sense of, well, are you providing the needs and beyond that of learning, but are you providing the needs of safety and inclusivity and esteem? Those like Maslow's hierarchy of needs types of things that like, are you providing a basic level of like physiological needs? Are you allowing students to have snack breaks and bring water and go to the bathroom? Like those physiological needs.
I thought we were going to disagree on this.
I hope not. What?
Snack breaks? What is... I figured you're a pediatrician. Is that what you guys did in wards?
I know in the ED we do snack breaks. We do not do that. But everybody's little break to eat something.
I will say during my month in the ER as an intern, that blew my mind when I came for like my 8-hour shift. And I'm like, okay, when do we eat? And they looked at me like, you may get a handful of crackers in between patients. I was like, wait, what in the world? And I left my little lunch that I packed and it was sitting 6 feet away in the break room, and I didn't get to see it the whole 8-hour shift.
Oh my goodness.
So yeah, you be working differently. My thoughts are, it's a couple of things, because obviously what you all said was correct about prioritizing learners, but the other side is, and I did respond to the tweet, but there's so many different things as you become an attending, and you may be at an academic medical center, you may be at a community hospital. As you're, did you take a job at a traditional teaching hospital? Are you at a community hospital with an adjunct educational assignment? There's so many things and competing interests when you get that job as an attending. I was in the Navy. I had residents. I taught, and I thoroughly enjoy medical school resident education. But when I was a resident, I was like, oh, this is going to be like a huge portion of my career and my focus. But as an attending, it's like I don't want to be in the hospital. I don't want to work. I enjoy my job. I'm not doing this on my free time just because I enjoy it. I have a whole family. I have a life. I want to go on vacation. I'm negotiating for a raise. So I think that greater context, it very quickly diminished like all those aspirations I had of being the fantastic educator that I always wanted as a resident.
Well, because you think you think that distracted from your ability to also want to teach.
Yeah, I think it was lower on my list of priorities once I had attained that level, I guess.
Right. I think it's interesting. For me, I love teaching. I love teaching more bedside teaching than I like actual like lectures and stuff.
Agreed. I hate it because I hated sitting through lectures as a medical student and resident. People are like, oh, chalk talk. And they start talking and I'm like, no, please stop.
Right. Also, I have terrible ADHD, so it's not good for me. But I think also this is why I feel like I'm very grateful for the educators that I came across in my training that like I've learned to model their behavior. So I would say like my program director in residency, who was at PEMDoc, and then obviously my program directors in attendings and fellowship.
PDM, that's what you're
PEM, Pediatric Emergency Medicine. I think they always centered learning with clinical care and patient care. So I think that I always knew that it was coupled with my job and I enjoyed it. And I also would try to find ways to incorporate it. So trying to figure out like teaching pearls after someone presents to me and like, okay, cool. That's bronchiolitis. But not everything that wheezes is bronchiolitis. These are other things we think about. And sometimes I'm listening to presentations and I already know what I'm going to do for a patient, but I'm listening to figure out where my teaching points are going to be. And that's why I always tell residents and students, so when you're presenting to me, just come up with something, because it's hard for me to guide your learning if I don't know where you're coming from. But I don't know. For me, I was always trained to tie them together. And so when I was in clinical environments where I wasn't teaching, it felt very alien to me. It felt like hollow in some ways, because I do enjoy teaching. And I think I can take care of bronchiolitis and all types of pediatric patients solo all day if I wanted to. But I think there's a part of my job that I would miss if I didn't have that sort of just teaching educational component to it. So I don't know. I don't know if that's more specialty specific or if it's more like personally, like individuals. I do know every PEM doc likes to teach. I will tell you that. Or not everyone should be teaching. So I don't know. I don't know if it's different in surgery or in anesthesia because your clinical environments are different from ours. So
yeah, one of the things I realized along the way, and I had a lot of time to reflect in the Navy, but you think an organization is one way because it's like the military. Everybody's upstanding. Everybody wears a uniform. It's always like very polished, proper organization. Then I showed up and I'm like, oh, these are the same people that I've worked with at Subway. I went to school with, I was in residency with. And you realize throughout life, there's just variations of the same people. So you're angry medical school classmate or had a classmate that was cheating. Right. Well, you're going to become a resident and you're going to be angry. You're going to be cheating. Right. You're going to be promiscuous. Right. You're going to become an attending who is all of the above. If you're a nurse and that was your personality. And so in that perspective, some attendings are a-holes. And they're not very nice. Sometimes I'm not the nicest person. We could dig into that. It is consistent. So I was like, don't be surprised there's mean people that are your attendings. And fortunately, sometimes the best you can do is say, hey, when I'm that person, I'm not going to handle things the way they are.
So interesting. I was actually recently thinking about this past week because I've had encounters with learners who have told me stories about their terrible experiences with certain attendings back in their life.
Your partners?
Not my colleagues, like other people. Oh, okay. I mean, badmouth my colleagues. Get me caught up.
I'll share a story about that. But yeah.
Right. And sorry, where was I going with that? Crap. Sorry.
Students were telling you about bad experiences.
Yes. And you were saying earlier, personalities. Okay. So it's interesting because when I'm going into shift, sometimes I go into a shift and I am having like a terrible day. I'm in a terrible mood. I don't want to be here. I don't want to do this. It's so much time. I want to go home and relax. And when I'm walking into a purely clinical environment, like our community-based hospital versus like our academic hospital, is very different. When I go into the academic setting, I think I'm constantly like immediately once the shift starts, just sort of say like, you know what, whatever's going on in my life has nothing to do with these people. It has nothing to do with, even if the system is terrible, the system isn't terrible because the resident messed up. Like the system is terrible because of other people and I can give them my energy later. But it's not fair for a person who like is also working with way more than I'm working, who's more new to this field, who is very impressionable. And it's not fair that I come into the space and carry my baggage or my bad tendencies onto them. I also firmly detest the idea that like people's personality is like, well, just the way I am, I'm just an asshole. Well, then maybe you shouldn't be a teacher. Like at the end of the day, if you are telling people that like your personality is the conducive to unsafe learning environments and you are unwilling or unable to actually change that, then you should not be part of the learning environment. And that I'm a firm believer of that because I don't believe that people should be terrorizing students just because you personally feel bad or you personally have some like personality quirk. Like,
but what if it was a good job for you?
It's a good job. You better find something else to do. Like, I mean, granted, like I'm speaking from the defense of the learners. I mean, from that of the attending, I feel like, I don't know, it just creates a terrible culture. Like then also I think you train other residents to act like that. And just like you're modeling behavior that I feel like is inappropriate. And so I don't know if it's a really good job and people are like, well, I don't want to lose my job, but I also don't want to teach. Well, then I don't know how. I think if I was your boss, I'd be like, well, what are your evaluations saying? Because if your evaluations are telling me that people think you're an asshole, then you shouldn't have this job either.
It's leadership.
Yeah, right. It goes up to leadership. And so who creates safe learning environments and also calling out your colleagues and other people that may be contributing to it. I don't know. I think people have their own ways of doing things. So, but your evals 100%. Do matter. Yeah. Your evals do matter. So students, residents, make sure you do those evals and be honest about them too. They should be anonymous and they actually go a very far way depending on the institution on attending's ability to get promoted and things like that. So.
Yeah. And I think that speaks to the leadership because you could, as a department chair or program director or whatever, people join the organization for various reasons. Some are fantastic teachers. Some just wanted to live in Chicago and get a job.
Right.
But as you're sifting through those evals and you're hearing these stories, it's your job as a leader to say, hey, this is a great clinician.
Right.
But maybe they won't get medical students. Or maybe you'll need to request this person, right? And that comes from the top down.
Right.
It's going to be some extra work, but that's what, if you really care about learners, then that's some of the work you could do. And you mentioned policing your colleagues. And I had a story. I had a colleague in the Navy. What was he saying? This man, he was crazy. He was an angry person, a very angry person.
Oh, God.
And it came to my knowledge, one of the scrub techs, Troy was like, Dr. Bradley, he tells the residents that he's their anesthesia daddy.
Oh my goodness.
And he was having my residents call him, I'm your anesthesia daddy. And, and I heard one or two. So I went to the resident. I was like, hey, is this so-and-so?
Right.
Does he make you call him your anesthesia daddy?
Right.
And they're laughing because it's a joke. But I'm like, This is very uncomfortable. So we're in the office. I said, hey, man. And I'm sitting there like thinking, how do I like be cool and confront my colleague? I'll lean back in my chair like, hey, man, what's this about? You being so-and-so's anesthesia daddy?
Right.
And then he like had that real uncomfortable laugh. And I was like, yeah, that's not okay, man. You need to stop. Don't do that.
Good for you. That's crazy.
But
wow.
It's when you hear about these stories, so from an attending perspective, when you have colleagues that are malignant, and we know in medicine, some people will pride themselves on being malignant. Oh, that's just where I am. This is where I teach it. It is our job to address that within the power constructs in our professional relationships.
Right. And what do you think about that in setting of not even just your colleagues, like other like residents and students are the ones who are actually also contributing to like environment? Because I'll tell you, sir, when I was a resident, I was a senior resident in the ED, and my attending, who's my program director, one of my colleagues in the ED, we work with a general ED residents, those who do predominantly adults, and then pediatric residents. And so I was a senior pediatric resident with an pediatric intern, and there was two other general ED residents. And the pediatric intern was like just asking just a general question about like laceration repair and everything. And I think the ED residents were just like, really giving a hard time about it. And then my program director and my attending just overheard it and just got the intern. I was like, hey, let me just show you how to do it. And just took them away from that situation and just walked them through the laceration repair. And I never forget that level of kindness. She could have just sat there and not said anything. She could have just let that whole conversation happen and let the intern be uncomfortable. But I think she saw that, knew the power that she had to prevent that. And I think create a better environment for that learner. And that model, again, this is why I'm talking about, I see the behavior of people who have trained me, and I try to emulate them, all the positive traits as best possible. But when I see other like residents or other trainees or students contributing to a negative environment, I also struggle with it. Sometimes trying to be able to correct it in some ways, but I try to. So I don't know if you had similar experiences.
I've spoken before how when I'm trying to get somewhere and I'm an intern or when I got something to lose, I'm very quiet.
Right.
But now I got my degrees. I'm board certified. Like, you're not going to shut me up. So in a situation like that, I would have called her. I was like, hey, ER resident, are you good?
Right.
Are you okay? What's going on?
Right.
And then they're going to be like, they're going to get real awkward. And then I would have taken them. But I've gotten to a point where when I have nothing to lose, was it the steamboat in Alabama when the dude threw the hat up in the air?
Oh, yeah.
And then it just set it off. All right, here we go.
Right.
So I just try to like confront things head on. And then I do the same thing with the residents, because my pet peeve in residency was evaluations and how quickly my attendings would write down a bad evaluation.
Right.
Would never speak to me. I'd see the information weeks later. And then for me, not only do I have a bad eval, I didn't have an opportunity to correct my behavior at that point in time. And now I don't trust you. I feel this is a very negative feeling. So I've said I'm not a very nice person, but I say that in the context of, in terms of residents, I'm not there to be my friend. You could talk to the resident I had in the Navy. I was a teacher of the year.
I was like, most likely, I don't think you not being a nice person seems unrealistic.
The two things I did. Number one, I was very direct in terms of teaching. I would sit back, I would have them do their inductions or whatever, make their judgment calls or whatever. And I would there to protect the patient, all that.
Right.
But then I would give them detailed feedback on everything that we did. When it was a safe time, I waited till like, you're not looking at the patient and listen to me. Like, no, you have a second for feedback. And I would usually try to label it as feedback. At the end of the day, let's do some feedback. And then I would go through everything that I saw was wrong. I would talk about in the literature, this doesn't matter. This is a personal preference of mine, right? Because every attending has their personal preferences that they want to teach, like it's the Holy Scripture. And I say, no, this is the way I do things. It's not right or wrong. And then if I was going to give a bad evaluation, I'm like, hey, yeah, I can only give you like a 4 out of 10 for XYZ. Like I would tell them because for me, it's say with your chest. Instead of turn around and then write a bad evaluation. If I really felt that badly, I forced myself to tell them.
In front of them. That's actually pretty good.
So the second thing I did was to temper the way I gave feedback to the response that I was perceiving from that resident or that SRNA in the setting. Like some people thrive in that very intense traditional medicine, like antagonistic, like some people love that.
Right.
A lot. Some people don't. And you'll see them shut down if you approach them the wrong way. And so I try to be very sensitive to, okay, this person is shutting down, or I knew over time, like they need this type of education or correction. Sarcasm doesn't work with them. They might see some tears.
Right.
So
right.
I would temper and change the way I spoke to make sure that it was that safe learning environment.
Right. And I think that's a better way of doing it too, in some ways, thinking about being direct, especially if you're going to give feedback that's going to be less than desirable. And I also think, I think tempering to the personality of the resident, because I've had residents do terrible jobs and find out they're going through some terrible thing in their life. And I'm like, okay, give people grace and compassion. I think there are very few things I think a trainee or a student can do besides actively discriminate against people and cause terrible work environments. Because to me, that actually makes my day terrible. At the end of the day, is I'm not really like I get more angry at like systems and like leadership and those level of like redundancies. But when it comes to like actual learning, I feel like, I don't know, I try to temper it down to understand that you never know what anyone's going through. And the fact that like some of the residents have to go through 15, 16 shifts a month and they're working like 8-hour shifts here, but maybe they're doing 12-hour shifts back at their home institution. And there's just so many other things that you just have to give people grace for that you don't know. And your job is to create a learning environment. And I always believe when my one attending said in the NICU was that like, I give you the illusion that you make your own decisions. I give you the illusion that because the whole idea is that like, this is a learning environment, it's a training ground, but we're also taking care of people at the same time. So there's a balance that you have to play. So it is one or the, for some people it's one or the other. Some people like to do hours of teaching and no work. And some people like to do all work and no teaching. And it's a balance. I have one of my evals, I think my first year was, with most of my evals were great. One of it was balancing the flow of the ER with learning. And it wasn't bad. I think it was the resident gave me some compassion. It was a very busy day.
It's tough. It's tough to read.
It's hard. But I also I really do, and not enjoy, but I do want to know areas of growth in it. And one of it was pretty much just like balancing that flow and teaching. Because sometimes I become very efficient and I'm just like, okay, just tell me the assessment plan and what you think is going on and we'll move forward from there. And because I just want to get things moving. And not realizing that sometimes I'm robbing them of opportunities to trial how to do a full presentation, to figure out a plan. Sometimes I'm answering questions from nurses before the resident had the time to speak. And so I had to learn to step back a little bit, but that's also about creating a safe learning environment. What I was curious about is more so like our experiences going through training in spaces that weren't so safe and how that impacted our learning and impacted not only our learning, but also our self-esteem. I think it's also, and how that worked. Because I think, for me, I remember when I started fellowship, the first day of fellowship, I remember in residency, I like never asked a single question. I was like, if I don't know what's going on, I was going to look it up and figure it out. But I would never ask questions because I was always afraid that I was going to ask the dumb question. Everyone knew the answer and I was the one person who didn't pay attention to that one lecture. But I also realized that it slowed down my learning because instead of doing a combination of both like self-learning and being taught, I was literally just bottling up things, not trying things. And in fellowship, I was like, I'm just going to do it. I'm going to try. I'm going to say things. I'm going to speak up in lecture. And of course, it took me like 2 years to figure that out, how to do that. But I think largely because I was so used to learning environments where like you would be like chastised for not knowing basic things. And there wasn't a level of safety. So I don't know if now I feel like I go to conferences and like I feel like I can actually learn because I'm actually like not worried that someone's going to call me out about something. So I don't know if that's a similar thing for you.
Yeah, there's two things. One, to get around that, I recommend everybody download the Medscape app on your phone, because you can just literally Google whatever it is. And then as you're answering these questions, you can like actually do a little ask an educated question. That's one thing, because you got to fake it till you make it. That's some of those cheat codes. But number two, I think with regards to being in spaces that aren't for us, we don't know the opportunities that we've missed out on and the way we've been inappropriately judged. And I say that after I was sitting in a clinic there were like 4 medical students and 2 of them were Caucasian identifying, I assume, and then 2 Black students.
Right.
And the 2 white students were like just super chatty. Everything was cool. And this other students were sitting there real quiet. Everything was fine. But when it came time to talk about eval, those students were negative. It wasn't negative. It just wasn't positive. Like we're talking about 10 out of 10. the students that were engaging were getting the 9.5s and the 10s.
Right.
Whereas they're like, oh, well, we don't really know. We can't assess their knowledge, blah, blah, blah. And now you're getting a 6.5, 7,
Right.
8. And I realized that's when it clicked to me, like, we are being judged for not participating in these situations, in these spaces. And we may know all the answers.
Right.
But our silence is interpreted as ignorance and is penalized.
Right. It's always like you're judged not just for the questions you ask, but the questions you don't ask. And I think that's the thing is, I think in some ways, imagine how you have to feel safe to be able to speak up and to even answer a question and have grace in yourself to get it wrong, but also compassion from the educator to allow you to get it wrong. Right. I think, and if you're used to these spaces, if you're a white male and most of your educators are also look like you, and you feel, I imagine you'd feel safer. I definitely felt safer when I was in spaces that with my attendees that looked more like me, or at least established some level of like boundaries and reputation for being safe educators. And so I sometimes get jealous of that. I'm envious of that because I realize too, well, how many opportunities did I miss out on because I didn't speak up? But I'm also giving myself the grace to say, well, but also that wasn't just because of me. It was because of the environment that I entered into. And I guarantee you, if we entered ourselves into different environments, or those students themselves in a very opposite environment, they may not. They may not. That's ubiquitous of, I got to censor myself, of what I like to, like, I always call it like white confidence, which is to me the idea that like, it's like you could just be like completely confident about being completely wrong and no one's going to check you because of the way you look, because you're white. Yeah, and so then there's a cycle of feeds your confidence because no one's going to check you. You're going to keep doing it. So and then no one's going to keep checking you. So you're going to keep doing it. And then they're going to believe that you're confident. So they're not going to check you. So it's just, they're going to keep doing this cycle. And I've learned things from students like that have been completely wrong. And I've learned how certain attendees can't correct them or are unwilling to correct them.
Yes.
And I think that's terrible.
Yes. That's why I don't. Yeah, that's exactly what you described. Right. People have said wrong stuff, and I'm looking. I'm like, I'm not going to call you out. Then I look it up. I'm like, oh yeah, that was wrong.
That wrong. That didn't make any sense to me. but if you again, similar to what you said, fake it till you make it. But there is a level of, it's easier to fake it till you make it if you're coming into a system or an environment where they tell you belong. But when you're entering a system where it was not made for you to actually exist there, fake it till you make it feels very much like imposter syndrome, right? In a lot of ways, instead of us being confident, we are now more self-critical of who we are because we're in environments that are telling us to be more critical of who we are. So that's why I look at some people and I'm like, why is this the way you do it? Or what is going on? And you'll learn, even people like who come from very established, amazing institutions and don't know anything.
But now how about you being an attending now and you're teaching some learners that they don't think you know what you're talking about.
God, if I could have a freaking coin for every
don't lose your job now.
I know, right?
Lose your job.
Who is trying to tell me things about emergency medicine that like I'm like, does that make sense in real life? And have no concept of everything else. I mean, I think in my field we deal with the idea that obviously we're doing pediatrics and emergency medicine, and I think what people don't really understand is a large part of our ERs, our trainees are usually a general or adult ED residents, because you can imagine the amount of residents takes to staff in ED, and they all can't be pediatric residents. That would have drained the whole program. So and also to be in general EM residency, you need to have pediatric emergency medicine experience, because majority of kids go to general EDs. See the Wall Street Journal article that was just published last month about how only 14% of all EDs are pediatric ready, and why there's a huge disparity in child death. Anyway, so it's very common that I think when you have a second or third year like general ED resident, and they think they're so cocky because they've survived 2 years of residency, and they're going against your like 6 years of pediatric experience and an additional years of pediatric emergency medicine experience and dealing with pediatric patients, and they'll tell you like about like restoration and. In the beginning, I used to always just be like, it's okay, let them be themselves. They want to feel confident. Confidence is key. It's good, whatever. And then now I realize, but also humility is key. Like also in medicine, you have to be humble, because if you think everything, medicine will humble you, and it will be at your benefit to not be humbled in a very negative way that not only impacts you, but also can negatively impact a patient. And so there's often times where I try to approach these individuals with more of a questioning attitude to be like, well, why is that way? Where did you hear that from? Oh, what? And if you can't have a discussion about the points that you're so confident on, then maybe you don't know what you're talking about. Because you really should be able to like actually have a really good discussion about, well, this is why this is the case. And if you don't know, then know why that we don't know, right? It's an area of research that we don't know about. So anyway, that's my soapbox about, I think, the amount of, and I also wonder if my female colleagues have a similar experience with male residents, because I find it from a racial lens, but I wonder also from a gender and racial lens for Black female colleagues. It's crazy. It really is. Confidence is so,
and I think back to my Black women attendings at Howard, and I think about their faces when they're being mansplained to. And I always remember, oh, why aren't they snapping back? Or why aren't they saying? And they would just sit there absorbing the damage.
Right.
And then they would just handle it in the most elegant, professional way, but in a way that you messed up kind of deal. So that's what I've co-opted. Like I would just, okay, you're going to talk. You're okay. Keep talking. Talking.
Right.
Okay. So let's actually do this my way.
I'm going to let you burn yourself out. Eventually, we're going to do it my way. So
are you done? Okay. That's great. Yep. Maybe when you're finished with residency, you could do it that way. Today, we're going to do this. It's a bit of gamesmanship because if you don't want to hurt those egos because then they're just going to be.
I know they're going to cry, and there's a whole thing about fragility and everything else. But I think that the ability to approach it with a questioning attitude, I think helps break because it's not. I think it's hard to argue that someone's being like quote unquote unprofessional, which is one of those hated terms. But it's also in an academic setting, and it's encouraged to be questioning. So I think and as an attending, I do want to be questioned because I learned so many different things about the ways of, why is it that we do this antibiotic versus the other one? Oh, I've always just done it this way. And I appreciate people force me to stop and to think. But when
there's a way to ask a question, though.
Right, exactly. when it's done in a way to show me like more, and it's okay. Are you trying to be a gunner? Are you challenging
me?
Why? It's unnecessary. And I hope I don't give off that persona that you need to, because I don't. It's not necessary. Like the way to it all out. So. I don't know. I feel like everyone needs to just... In medicine, I always tell people, it's not that serious. Everybody calm down. Because in medicine, everything's an argument. Everything is something to be proven. There are very few things I think in medicine that are like hardcore.
Absolutely.
This is always the right answer. There's so many different ways of doing things. And I think I'm trying to give that level of grace to learners, but also to myself. So,
and I think one of the highest qualities as we develop as an attending is the ability, especially in the OR.
Right.
I can let you attempt X, Y, Z 2 times, 3 times, because I'm very confident in my abilities to salvage the situation. Right. And so if you're a trainee, you may experience attendings that are very nonchalant and be like, all right, try that. And I think sometimes it's interpreted as, oh, Dr. Bradley doesn't know what he's doing. It's quite the opposite. Dr. Bradley knows that this isn't going to work.
Right.
And then we're going to do it this way, but I'm going to let you learn the hard way, the patient safe. But and I think that speaks to your skill set as you become a more experienced attending.
Right. Yeah. You just got let's go with the flow. And I think letting students and trainees make mistakes is how you learn. It's that part of the learning environment. It's one of the reasons why academic institutions are so inefficient, because there has to be a margin for error and mistakes to happen and to be inefficient, because that's how you learn. You don't learn by being perfect. If you enter the wards, you enter the ED, OR, and think you already know everything, then you really shouldn't be there. You don't have anything to learn. You know everything. Go do something else. Go figure something else out. But it's like you said, it's a lifeline journey. It's all about what we do. So
awesome. Well, I enjoyed unpacking. We started from a tweet, but here we are.
I know, we started from like DEI work to like ethics to a tweet about medical, about safe learning environments.
And I think if you have attendings that, I don't know that I have everything correct and I've got it perfect, maybe you can find my residents and be like, yo, was Dr. Bradley really all that? Or like tell them to get the real. But refer them to this podcast episode. Oh, hey, you need to work on your feedback. Why don't you listen to the Black Doctors podcast?
Right. I think the way I think about it is this might be from a workshop or a module we did at the medical school. But when we're thinking about environments, it is that massive hierarchy of needs. Like you're starting from like a basic physiological sense. Have you allowed students and trainees to just attend their physiological needs? Are they slept? Are they fed? Are they gone to the bathroom? Are they hydrated? And then going up from there, the physiologic, I think next is that esteem, like all safety, belonging, all those things are all important things that we're trying to make sure we check off so that they can reach the top of that, which is like self-actualization. So I think when we're thinking about learning environments is that we are responsible for everything except the top. But in order to get to the top, you have to start from the base. And I think that's how I think about like when I'm thinking about the environment I'm creating. Because when you enter the OR, when you enter the rounds or the ED, the attending really does create the environment. And I think that kind of power is what we should remember.
Yeah. No, that reminds me of a time I was a resident and one of the attendings said, "Oh, how was your weekend?" to like a co-resident. And they were like, "This says something that was like my dog died or something sad." And then the next words are, "All right, yeah, so for this case, I'm like, wait a minute." And again, I said, "Hey, you know what? I will never, ever do that." And when I ask, I genuinely ask, and I force myself. You're going to say, "Oh, how's your weekend?" They're going to answer. And then I usually force myself to ask at least one follow-up question because I'm like, so your Maslow's hierarchy, I've never really read that. I should probably look into that.
I feel like I have it on my little teaching app thingy. Or I
should probably look at it.
My folder of things. But yeah, it's just so I say this correctly. So it's physiologic. So that's the physiological needs, food, water, all those types of things. Safety and security, love and belonging, and esteem, like feeling accomplished. And then the top is self-actualization, which is achieving one's full potential. And so I think we're really responsible for doing safety is the biggest thing. Are we showing as safety as like physical safety? Are you going home? Is the resident going home too late, right? Are they too tired to drive home? Are we creating a safe place where they go home? Are they being threatened by a patient or their family? Are we creating safe spaces for them to be able to not be physically threatened by those types of things? And in a belonging sense, it goes back to what we talked about, even inclusive spaces for trainees and students of color, of all students, is like, are we actually including them in the discussion when we talk with patients? Or are we allowing them to speak up during a round? Or are we making them feel belonged, like showing them where to go to the bathroom, where the OR is, where the call rooms are? Like, are we actually doing those types of things? And I think that leads them to feeling esteemed and accomplished, because we try to give them, like, I try to lob very soft questions at residents initially to really get my, okay, good. Yeah. Or they'll ask a question. I usually always say, okay, if you're a resident, don't listen to this part. But I usually always say a good question, because the majority of the time they are good questions, but also because I want you to feel
positive,
confident, positive. Yeah. I don't want to be like, oh, this is a stupid question. Or when someone always says, oh, this is a very dumb question, but I'm like, girl, please, are you my dumb questions I ask on a regular basis? This is fine. But I think all that leads up to the ability to feel like fully self-actualized. I'm like, oh, I can be a fully autonomous physician. And we're all responsible for leading the next generation of us. So
yeah. God, all these tips. Again, when I ask a question, I give it like 5 seconds and then answer. Because I hate
pause. Yeah.
Oh, so why is the patient's blood pressure low?
Right.
And then we'll just be staring like, I don't know what you're thinking. And I'm not going to say anything. We can wait 30 seconds or a minute.
Right.
So as an attending, I ask, okay, so why is the person?
Right.
1, 2, 3, count to 3. Right, because it's small things like that.
Right,
I don't know. We're trying to move medicine forward,
push it forward. I think for me, I'm really bad with silence. So I ask a question and I look on their face and they're just like, and then I'm like, okay, well, let's look at like their medication. Is there something maybe they hear that I could give it? Are there any particular thing? I don't know. Are they on any beta blockers or calcium? What? And then trying to lead them, and they're like, oh. And then if they don't get it, then you just give them the teaching pearl. But yeah, no, I always used to hate it when my attending would be like, what? So why is this happening? And then in your brain, you're trying to understand the question, answer the question, and deal with the awkward silence at the same time. It's never good for me. It's so awkward. So yeah. Oh my God. So many times where that's for
God. We should do a list of tips for making medicine more conducive to
more safety in medicine. Create safe learning environments. I think that's like that's why I always like to try to write something out when I'm thinking about these things. Because I always try to, I don't know. And there's a lot of studies on it. There's a lot of work on this, and like how it goes back to what you said in the beginning of the episode, was that like, has medicine gotten better at this? I think it's definitely has more of a focus on it, and there's more of an appreciation of it, because we can't be raising broken physicians, right? It's not fair.
Yeah.
So
shoot. Well, it's a good time. Don't be a stranger. We'll get you back on. We'll get you like what, monthly appearances?
Hopefully, yeah. I'm around. You gotta talk to my people.
No, we're wrapping up. When this airs, we'll be wrapping up a birthday vacation in Mexico.
Oh, it's gonna be so much fun. I just have to survive this week, and then it's your birthday, and then it's the most important week, my birthday. I'm kidding. I'm kidding. No, I'm super excited. It's gonna be a really good time. And so for those of you who are getting through the holiday season and it's so cold and you're working late hours, we're here for you on this episode.
In Mexico.
In Mexico. All right, edit that part out. As I was saying that, I was like, we're actually not here for you. Don't call us.
Vacation notification zone. Oh, gosh. Well, thanks for joining. I always enjoy picking your brain and getting your thoughts on these crucial topics.
No worries. I'm always here.
Thanks for tuning in to the Black Doctors Podcast. We're here because representation matters.